Hello, and welcome to another in-depth Q&A with Dr. Hamid Djalilian. Today, we're going to be talking about his latest tinnitus research work, which includes a medication-based approach linked to migraines and a middle ear implant as well. Dr. Djalilian, it's great to have you with us.
Thank you. Thank you so much for inviting me and taking the time to talk.
Yeah, same. For those of you who don't know or recognize my face or even my voice, my name is JD Hairston. I'm a tinnitus patient myself who joined the ranks of the online global tinnitus community when I developed bothersome ringing in the summer of 2021. I since started a podcast, How I Got Tinnitus. That's how I always say it when I do the spiel, where I speak with patients, providers, and researchers about the topic. I've also been going back to school to research sensory perception, neuroscience, and psychology to better understand the subject. Dr. Djalilian, you may or may not remember, but we met briefly, I believe, last summer at TRI 2024 in Vancouver, where I was volunteering with Hazel for Tinnitus Quest.
Oh, yes, definitely.
Dr. Djalilian, while preparing for our chat, I listened to your Tinnitus Talk interview with Hazel and Brian Fargo. I mean, for me, it was a re-listen. It was really fun. But you shared towards the beginning of that talk your tinnitus research origin story. And you mentioned that during your residency, you asked yourself, what's the most difficult problem out there and how can it be solved? So now, years later, I'm curious, how's the problem solving going?
I think actually after probably close to, it's not quite 30 years, but maybe had a little between 25 and 30 years, um, I think we have a pretty good grip on some of the aspects of tinnitus in terms of how to treat it medically, and what the processes are that are involved in making tinnitus loud, and possibly what the very early stages of tinnitus involve. And secondarily, I think we're closer to a device that can potentially silence tinnitus. So I'm actually very excited. I think this is sort of compared to what we knew, 25 years ago, we're leaps and bounds more advanced in what we know, and I think we're much closer to a cure than we were all those years ago.
Mm-hmm. And we're going to be diving into some pretty in-depth questions that have been submitted for you from the Discord. I'll admit I had to spend some time with these to brush up on some of the science behind it. So bear with me as I sit here, the student at the meets the teacher. So let's just get into it. We want to start with some of your work related to tinnitus as it relates to migraines, which is something that I remember hearing you speak about at TRI. So our first question that was submitted goes like this. What is the specific neurophysiological rationale for describing fluctuating or reactive tinnitus as an atypical migraine phenomenon? It goes on. Which brain centers and pathways do you consider most relevant in this process?
Sure. So I want to sort of, just as a way of background, talk about what really a migraine is. And we're more and more using a different sort of nomenclature to describe what actually happens. So, migraine traditionally has been thought about as being a problem of blood vessels in the brain and dilation and contraction of those blood vessels causing symptoms and associated with headaches. But really what we understand now is that migraine is more what we call a central processing or sensory processing disorder, where the brain gets very sensitive, and that sensitivity is what leads to a lot of the manifestations of that process. Now, one of those manifestations is a migraine headache. A different manifestation of that central sensitization is this tinnitus phenomenon, where tinnitus becomes very loud and bothersome. In the brain, there is always this balance between excitation and inhibition. And for many years, everyone has been focused on really headache as being sort of the main manifestation of this. But now we understand there are actually a lot of other issues. And some of the research done by Professor De Ridder is also talks about how a lot of these mechanisms, these in tinnitus, are similar to chronic pain. And chronic pain is actually another form of central sensitization. It's treated in the same way as we treat, migraine. Same kinds of medications from a preventative standpoint are used to sort of stabilize the nerve, but these are all kind of central acting medications. So there's this sort of balance in excitation inhibition, which is the balance between the so-called glutaminergic activity, which is driven by glutamate, and GABAergic inhibition, which is gone through the GABA sort of mechanism. Now, the brain becomes sensitive. There's this amplification of sensory inputs. And there is sort of a debate on whether there is a lowering of a threshold or if it's an increase in brain activity that gets above the threshold that then triggers this process. But whichever it may be, it's basically you have activity. Everyone's kind of has a somewhat of predetermined threshold, which is probably related more to genetics than anything else. And once you reach above threshold, then the symptoms will start manifesting. And those symptoms could be headaches in some people, but it could just be loud tinnitus in other people. Now, where is this occurring in the brain? There are several areas that at least have been studied. One is the one that probably people may be familiar with, which is called the thalamocortical dysrhythmia, which is this sort of rhythm-like activity that occurs between the thalamus and the cortex. And there's been a lot of work by Professor De Ridder and Professor Longut, Sven Van Nest on this area where this appears to be a critical factor in tinnitus. Now, that thalamocortical dysrhythmia is also a big factor in migraine as well. So, and we see that in chronic pain as well. So these are all conditions of central sensitivity. Tinnitus is one manifestation. Migraine is a different manifestation. Now, people who get the tinnitus may get a lot of migraine symptoms, but not all of them have migraine, in terms of headaches. They just get what we call atypical migraine, which is a lot of other things. Now, other areas of the brain, I think, that are involved are, of course, the trigeminal system. The trigeminal nerve is the nerve that supplies sensation to basically from here all the way to the top of the head. But the trigeminal nerve also has this area that sort of interacts with the cervical system, that's sort of the neck system. So a lot of patients with this atypical form of migraine or the central sensitization get neck stiffness as one of their manifestations. So people who have tinnitus and neck stiffness are also, that sort of tells me that there's this same process that's active. Now, activation of the trigeminal system can lead to headaches in some people. It can lead to neck stiffness in some people. It can lead to fullness in the ear in some people. It can lead to sinus headaches in some people. It just depends on what part of that trigeminal nerve is affected. Now, in addition, the trigeminal nerve has branches that go to the intracranial blood vessels, the blood vessels that supply pretty much everything inside the head. And one of those branches from the sort of first branch of the trigeminal nerve goes to the blood vessel that feeds the inner ear. And people who may be experiencing these sort of what we call fleeting sort of short-term tinnitus, where they get this kind of loud ringing for about 20 seconds, their ear feels muffled, they may feel fullness, and then it sort of kind of dissipates slowly, or generally no more than 30 seconds or so. That's the action, we believe, of the trigeminal nerve on the blood vessel that feeds the inner ear, which is causing a temporary loss of hearing and then this increase in loudness centrally which then the sort of whatever that if it's a dilation or contraction sort of lets up, and then everything is kind of goes back to baseline. So there are different ways that things are involved. One is through the trigeminal nerve system. One is the thalamocortical dysrhythmia. One is the sort of the neurogenic inflammation led by trigeminal nerve, which is the sort of through the CGRP pathway, which is kind of the new drugs for, which we'll answer. There's a question about that later that we'll talk about. And I think the dorsal cochlear nucleus is involved in tinnitus as sort of one of the, based on a lot of the studies that have been done. There is this imbalance in excitation and inhibition. So there's this increase in the spontaneous firing rate there. But that is not probably the only factor involved. We believe that there's a secondary factor that causes the fluctuation in tinnitus, the change in the levels of tinnitus, the change in the perception of tinnitus, and probably in the very early stages where people are getting intermittent tinnitus, that process is involved. So I would say it's a multi-systematic thing. I mean, do I claim to know all of it? No, I don't. I mean, I think this is based on my understanding of the neuroscience of it and what's involved. But I think there would be probably more systems that would be discovered that may be involved in this. But at least from what we know of what occurs in migraine and how it overlaps in patients with tinnitus, especially the sort of one of the newest papers that came out from the Dr. De Ridder and Van Nest, where they had these patients who had on and off tinnitus and looking at what happens, during those times. It all overlaps with the same processes that occur actually in migraine.
I'm wondering if it's not too much of a left field question here. I had my own follow-up question to that one, which is, could you elaborate on how that central sensitivity might differ between those with and without a history of migraine?
Yeah, that's a great question. So central sensitivity occurs in both groups. So in some people, likely due to some, we believe, and we hope to do these studies at some point, some epigenetic changes. So basically, currently sort of migraine is thought to be genetic, but the manifestation differs, generation to generation or, sibling to sibling. And that may be because there are some changes that occur to the genetics, which then turn off portions of the gene and cause different types of symptoms. But I should tell you also that if you follow these patients long enough, you will start seeing all of these different symptoms at different times of their lives. So there are a lot of patients who say, I used to get headaches when I was, in my 20s. And I don't get headaches anymore. Right now, I just get this tinnitus that goes up and down. Or usually they'll say, something that triggers these episodes where they get intermittent tinnitus. And then during those episodes, they'll get maybe neck stiffness, or they'll get sinus pressure, or they'll get ear pressure. Those are all sort of part of that same central sensitization issue. It's just that the manifestations differ in different people and at different times of their lives. Now, why that is, I don't have a great explanation yet. But I think, those are things that we have to figure out. But it's very common, at least in women, that we see that around menopause time, the manifestations of the central sensitization tend to be more atypical symptoms. Whereas when women are younger and they get hormonal fluctuation, they tend to get more the classic migraine symptoms, like more headache type symptoms. In men, because men don't get hormonal fluctuation as much, that tends to not be in sort of an age-related issue. But I have seen men who started developing loud tinnitus with the use of testosterone supplementation, which creates kind of an unnatural fluctuation to the sex hormones in the body.
Thank you. I was trying to go through my notes because there was a paper published this year linking hormonal fluctuations in women with increased tinnitus perception. I was trying to pull that one up. But anyway, love this stuff. You know, it that question seems like a good place to go to this next one, which is, a lot of us who are new to the whole tinnitus migraine connection, uh, might just be kind of curious. What clinical imaging findings or what other evidence do you find that strongly supports the idea that tinnitus can be migraine-like or linked to migraines? And for those who don't have a classic migraine history, how do you account for the potential crossover in mechanisms?
Sure. I think the umbrella condition is the central sensitization. In some people, the manifestation is a headache. In some people, it's tinnitus. Some people get both. Now, um, if we look at the so-called classic migraine headaches, um, uh, and these are studies that have been done in the United States, that the study that we did of about 13,000 people, where people with migraine were more likely to have tinnitus, and more people with tinnitus were more likely to have migraine. There was a similar study done in the Taiwanese population that found the same thing. They found about 3 times more chance of developing tinnitus in people with a history of migraine. And they took people who had had at least 3 visits to physicians and had had a diagnosis of migraine. So these are people who had more severe symptoms. So the more severe the migraine, the more likely you are to get to tinnitus. And then there was a study by Professor Longuth in Germany that showed that 44.6% of patients with tinnitus have migraine. So there is this epidemiologic evidence that there is way more sort of prevalence of migraine in people with tinnitus, and way more tinnitus occurring in people with a history of migraine. And that's just taking the people with migraine headaches. That's not taking into account the atypical form, which oftentimes will not get diagnosed as migraine and will not be recognized by patients as being a migraine symptom. And those are things like, as I mentioned, neck stiffness, sinus pressure, sinus pain, ear pressure, hyperacusis. These are all like atypical forms of this central sensitization, or atypical migraine, basically. So first, just looking at just headache, there is this big overlap. There have shared triggers. That's sort of a critical thing, where we see, most people with tinnitus at the very onset of it had either a major stressor in their life, had sleep issues, or sometimes dietary related issues, hormonal changes related issues. Those are all same triggers that trigger migraine headaches: stress, sleep, diet, hormonal changes, and overstimulation, like loud sound. So loud sound can trigger a migraine. Loud sound can cause tinnitus to become louder from the reactive type of tinnitus. So that's sort of the one component of it. And that's really how I started noticing that there's so much overlap between patients with tinnitus and what they said would make their tinnitus worse, and what patients with other atypical forms of migraine, most commonly what I see is vertigo, is that people with vertigo had the same triggers as the people with tinnitus. And as I said, there must be some sort of common etiology. And as we understand, now that most forms of vertigo actually lead up to this central sensitization issue, that made me think maybe tinnitus is the same. And so we started treating tinnitus as this basically a migraine-like issue, or atypical migraine form, and we saw response. So part of it is that we see a response to the treatment. We talked about the thalamocortical dysrhythmia, which is the same phenomenon that we see both in migraine and tinnitus. The neurogenic inflammation and CGRP-related activity is also something we see in both. I talked about the migraine-induced maybe vasospasm or vasodilation. We actually don't know for sure that causes temporary change in tinnitus. But based on animal studies, when there is stimulation of the first branch of the trigeminal nerve, there is a vasodilation in the blood vessel that feeds the cochlea, and there's a lot of fluid that comes out of the blood vessels within the cochlea. So there are some changes that occur as a result of trigeminal nerve stimulation in the inner ear, which can cause hearing loss. Like sudden hearing loss is one of, in a lot of people, is migraine related. And people, when we treat people with sudden hearing loss with migraine medications, in addition to the traditional therapy, they actually get much more hearing back than traditional treatment, which is injections in the ear and steroid pills. I think the other things are the salience network, which is what causes sort of basically the brain to prioritize information. That's involved at both migraine and tinnitus. And then, as I said, that they both respond to the same medications, and that's sort of been basically our approach to the medical therapy of migraine, is approaching this as if we were treating central sensitization, how would we treat it? That's a combination of medications and using lifestyle and dietary changes, which is what's really most effective for treating migraine, and what we found to be very effective for treating bothersome, loud tinnitus, fluctuating tinnitus, somatic type tinnitus, and we'll talk about which patients are going to benefit most, I think, a little later. But I just wanted to mention those.
Yeah, and that's great. And I think you touched on much of the content of two other questions that I'm looking at right now, which is, how do you reconcile this view with somatic triggers that can also contribute to tinnitus? Sorry, I code switched there. But
sure,
go ahead.
Yeah, okay, go ahead. Do you want me to?
Well,
because there are some things I can talk about in that I haven't talked about.
And I sort of had my own follow-up to that, which is how do you integrate the brain sensitivity with the somatic factors? Like, is it a constant continuum? How do you differentiate the two and the influence of each?
Sure. So the central sensitivity will lead to activation of the so-called trigeminal system. That trigeminal system activation will lead to various symptoms. The trigeminal nerve is primarily sensory to, as I said, from here to here. It supplies the sensation to the coverings of the brain, the dura. It supplies all of the blood vessels inside the brain. And it supplies some muscles in our head and neck. The muscles are the muscles that are involved with chewing. So a lot of times the muscle here called masseter muscle, the temporalis muscle, these can go into like a spasm from an increase in activity of that trigeminal nerve. Because when that trigeminal nerve becomes active, it produces these molecules at the end of the nerve into the muscles or into the sensation areas, which then cause pain. So these are things like CGRP and so-called substance P. These will cause inflammation in that area. That inflammation what's called neurogenic inflammation, so inflammation caused by nerve, that will then lead to symptoms. So you can get tension of the muscles of the jaw. So both muscle here, the muscles that are inside the jaw that help with closing of the jaw and pushing the jaw forward and backward. So a lot of times people think that their TMJ symptoms are causing their tinnitus. But what actually is occurring is the trigeminal nerve activation is causing the TMJ symptoms, and the same central sensitization, which led to increase in the trigeminal nerve activity, is what's making the tinnitus louder. So it's the same process that's leading to both things rather than TMJ symptoms causing that. Or sometimes people say neck pain, and we talked about the trigeminal cervical complex, which is basically the interaction between the cervical nerves, the neck nerves, and the trigeminal nerve. And that can cause changes where you get the same phenomenon that you get in the jaw, you get in the neck muscles. So you get tension in the neck, and people feel like their neck is stiff. They have to kind of, stretch it or massage it and things like that. And they think that that is what's causing the tinnitus, when in fact, it's really the same central process is causing both of those things, just through different mechanisms. One is through the trigeminal nerve, one is just through the central sensitization. And oftentimes when I see patients who say, "Oh, it's my TMJ that's causing this," and I examine their TMJ, their TMJ is normal. They actually have no problems with the joint. They just have muscle tension, and that muscle tension is due to that. Now, the sort of the some of the treatments that are done for these muscle aches, like massaging the muscle and or warming it and things like that, creates symptomatic relief, which helps reduce the activation of the trigeminal nerve, because there is this feedback loop, because the trigeminal nerve causes inflammation that causes tension and pain. The pain activates further centrally and becomes amplified more, which then causes more trigeminal nerve stimulation. And that kind of creates this feedback loop, which then creates symptoms more and more for the jaw, TMJ, and facial pain, neck pain, etc. But by kind of breaking that cycle, by doing these things, then that tends to help. So I think there is some merit. I can't say it's really a good a problem that's solving the problem, or it's a solution that's solving the problem, but rather I think there's some merit to doing some of these things. So doing things for symptomatic relief, like massage and warming things and stuff like that. Is that going to fix tinnitus? No, because the way I approach it is I want to approach it where it's starting in the brain, rather than kind of band-aid it at the periphery where we're seeing the symptoms. Now, I should say that when you look at people with so-called TMJ dysfunction, who have been in studies done by oral surgery, who tend to see the TMJ related problems, that they see is anywhere from 60 to 70% of patients with TMJ disorders have a history of migraine. And as I mentioned, when they've looked at actually sinus headaches, so this sort of sinus headaches which people experience over the cheeks, over the forehead, people with chronic sinus headaches, 88% of them have migraine. But a lot of times it's just not recognized because it's over the sinuses. They don't go to a neurologist. They end up going to an ENT sometimes because they think it's a sinus issue. The ENT may not diagnose it correctly. A lot of times they're treated with antibiotics and nasal sprays and sometimes surgery for something that has nothing to do with the sinuses. It's just comes as nerves in the brain. And the fullness in the ear that we see is again another trigeminal nerve activity, because the third branch of the trigeminal nerve, which supplies the muscles of the chewing, also supplies the muscle that goes behind the eardrum, called the tensor tympani muscle, and a sustained pulling of that muscle is what probably leads to this fullness sensation based on our understanding. And we've written several papers about the oral fullness being a manifestation of migraine and how it's treatable. And when we treat it, people get better. So I think there is, again, multiple pathways. The TMJ neck pain, they're all driven through the trigeminal system. One is through the cervical, one is through the so-called V3, or the third branch of the trigeminal nerve. There is, increase in sensitization. So pain in these areas will increase activity at the brain level, which then further can create problems. So what I tell patients is, like one of the triggers of migraine or tinnitus, for example, is stress. But stress isn't just psychological stress. Anywhere you have pain in your body, if you have a major inflammatory process in your body, that's perceived as stress for the brain. So your brain's going to have the same reaction. So if you have pain in the neck and that bothers you, that will then create a central action, which then further perpetuates the problem. So sometimes breaking the cycle by doing some symptomatic treatment helps, but our sort of approach has been to treat it centrally.
Thank you. Well, so it makes me think about this other question about what is your perspective on individuals whose tinnitus is stable and non-reactive? So it sounds like you just spoke to people who can sort of link it to some sort of recent or momentary cause, but do you believe that migraine-based approach could benefit someone like me who's my tinnitus is probably noise-induced, and I don't necessarily associate it with something like TMJ or
Sure.
migraine?
Yeah, I mean, so it depends. So, if somebody comes to me and they say, my tinnitus, I've had it for 25 years. It's never changed. It's always there. Um, you know, when there's noise around, I don't really notice it much, but when it's quiet, I hear it. That's not migraine related. That's just now their baseline. That's the baseline tinnitus. That's what we can get people down to with the treatment. But if somebody comes and says, I hear it all the time, even like when I'm talking to you, it's there. That tells me there is some action that's causing this to be more sort of apparent to them. And there's more concentration sort of centrally on the process. And that is what can be treated. Now, in your particular case, I don't know, but what I can tell you that, from patients that I talk to, uh, a lot of the ones who come to me and say, yeah, my tinnitus is always the same. And I say, well, does it ever change? And say, well, yeah, I mean, like when I take an airplane travel or something, the tinnitus gets temporarily louder after that. Or if I'm upset about something, it'll get louder. Or if I don't eat breakfast or something, it'll get louder. Those are the things that fluctuation is what that central sensitization or atypical migraine does. Um, the only other group that we see are people who say, because there is this phenomenon we call status migrainosis, where basically you have a constant migraine. As long as you're living above that threshold, you have this active migraine process. Now, when it's a headache, it's recognized, so people are treated with medications quickly. But when it's tinnitus, it's not recognized. And those are people who can say they used to have quiet tinnitus, and it was barely perceptible. And then suddenly it changes to become very loud. And that change usually is associated with major stress, a procedure. Like a lot of times we see it after dental procedures, or sometimes ear surgeries and things like that, or brain intracranial surgery. Anything that stimulates the trigeminal nerve can trigger it. I've seen it after eye surgery, where it suddenly becomes loud. And we see it after, probably the most common thing we see it after nowadays is after getting COVID or the vaccination, because those create a major inflammatory response in the body. And then that can trigger this central sensitization. So if you look at vaccine trials and we look at how many people end up getting tinnitus in a vaccine trial, I'm sorry, in a migraine, a headache in a vaccine trial. So if it's like the shingles vaccine or the influenza vaccine, it's somewhere in the about 20% range of people will have a headache shortly after that. With the COVID vaccine, because it was a different form of vaccine, it was the so-called mRNA vaccine, it creates a much bigger inflammatory response. And that then leads to a much higher incidence of migraine. So the COVID vaccination, when we've looked at it, it's about 37% of patients get vaccinated. So it's almost double what we see with other vaccinations. And then for the first time, probably in relatively modern history, you had, at least in the United States, 110 million people got vaccinated in a couple months time span. So it was very different than what's been done in past. So I've seen patients who've had increase in their tinnitus after influenza vaccine. But because it's sort of here and there, it's not necessarily recognized. But because a whole bunch of people got this vaccination in a short time span, and these people are now online, a lot of people are online in discussion groups. There's a lot of talking now. It's recognized. Oh, my tinnitus got worse after, and so then they recognize that maybe this was from the vaccination, which can happen. But that I should tell you that shouldn't discourage people from getting vaccinated, because I tell them if they want to get vaccinated, what they need to do in order to prepare for it, to get the vaccine, to reduce the likelihood of that central sensitization occurring from the vaccine. So you have to kind of go in prepared so that you're less likely to kind of go above threshold. But if somebody comes and says, it got worse after the vaccine, it is rare that we can't reduce the volume of their tinnitus by using the combination of medication, lifestyle changes, dietary changes, sleep optimization, and then using some targeted supplements. So, correct in that most people with stable, relatively quiet tinnitus probably don't have a migraine phenomenon. But if they do have little bits of fluctuation, it is from migraine. But some people who have a significant change in their baseline, they say, it used to be a 2 or 3, I barely noticed it, and now it's like a 7 or 8 all the time. Those are people who do have this central sensitization process. It's just active all the time. And the reason it stays active all the time most often is due to sleep problems. And I tell people a lot of times, because people say this can't be from the migraine process that you're talking about, because it distinctly happened after a loud noise, or it distinctly happened after I had the vaccination. And I tell them, yes, that's true. I know that that's how it started, but what's making it stay loud is a different cause than what started it. You used to live down here. The brain activity would go up and down on a daily basis. If you had bad sleep and poor and high stress and stuff would go down. As long as you didn't reach threshold, you were fine. You had the loud noise, it went up, let's say, or you got the vaccination, it went up, you went above threshold. Suddenly the tinnitus is really loud. And the brain wants to come back to its baseline. But then if you have poor sleep every night, or if you're not watching your diet every day, or you have high stress every day, or other things like hormonal fluctuation, loud noise exposure, overstimulation by various things, will keep you above that line for long term. I've had patients who've had it for years and was still able to reduce the volume. It's just recognizing what is maintaining it at sort of above threshold. So, in short answer to your question is that, sorry, after my 10-minute answer, is that yes, most people with quiet tinnitus probably don't have migraine, but people who have bothersome loud tinnitus most likely have something that's keeping it active, and it runs through that central sensitization because it responds to that treatment.
Mm-hmm, mm-hmm. Which makes me want to ask my own, again, another follow-up question. So I know the subject of objective measures in the tinnitus realm is a real spicy topic, but it makes me think about how in a lot of these cases where it seems to me like we're relying on um, just patient reports or anecdotal evidence. Is there any objective measure to support these sorts of triggers? Like, do we have any way to track whether or not this is just some, every time we tell a story or remember our past, we're actually distorting our own memory of it because it's changed in our telling. So, yeah, I don't know.
Yeah, that's a great question. I mean, right now we don't have an objective measure for tinnitus. That's something I'm interested in. Right now I don't have the bandwidth to work on, but it is something I actually have a great interest in. And we actually submitted a grant to the NIH, but unfortunately it didn't get accepted. So, but it is something that's of great interest to us. And currently there is a study that across multiple institutions related to using quantitative EEG to actually look at for a signature, if you may, which would then kind of more objectively determine whether somebody has tinnitus. That's still in the works. I think probably within a year there will be results, because I think they're in 6 or 7 institutions, and we're kind of I sort of found out about it a little late, but we are hopefully going to be part of the second phase of that study. So there is a large study looking for a signature, but currently we don't have one. So we have to rely on patient report. I mean, even when we think about it, let's say if somebody's studying pain or headaches or a lot of other things, we still have to rely on the patient to tell us. In the auditory sort of system, we call it psychoacoustic, in that we use acoustics, but then still it's a psycho, meaning the brain the patient's brain is what then has to tell us, what the sound is like and or whatever. When we're testing word understanding, of patients, and audiology, when we're testing most, audiogram, it's still technically subjective, but that doesn't take away from its ability to be able to be accurate when we're doing these things. So I think it's really the best tool we have currently. I think the tinnitus functional index is probably, the best tool. We are actually interested, our group is working on potentially kind of upgrading the tinnitus functional index to something that maybe is a little potentially less redundant in terms of the questions, and looks at other aspects of this, especially the fact that people have fluctuation in their symptoms. Because there's so many patients who come to me, they're like, I'm filling this out, but some days my tinnitus is an 8 and some days it's a 3. How do I report this on this thing? And because it's asking for an average, and that average takes away from the fact that some people have terribly bad loud tinnitus on some days. So that's an area of interest for me as well, to develop a new questionnaire that will take into account the nuances of tinnitus that the current questionnaires don't recognize. But I think at the end of the day, currently it's the best tool we have. It's what's used in many studies. It has some of the key questions we look for, which is loudness and annoyance. Do I think every question on there is a great question? No. And that's why we want to develop something that's hopefully better and a little bit more accurate and taking into account these fluctuations that a lot of patients experience. But I think it's the best tool we have currently until a better tool comes out, either through imaging or through something like quantitative EEG, which I think most likely will be the one that will be the case.
Mhm. I know even in my own early days of conducting informal interviews with friends or musicians that I met, or even folks through the podcast, I would always ask this question. I thought I was so clever. How, on a scale of 1 to 10, how loud is it? And yeah, I just very quickly realized that wasn't a really reliable or worthwhile question to ask most of the time, because it's so complex.
Correct. Yeah. And, as I said, we're going to look at basically the things we look for, because, when we're doing our clinical trials, part of the problem is when you average things out, then you lose a lot of the granularity of the data. And so, we need more granular data. How many days do you have loudness? How long does the loudness last? How loud is it on those days versus then the same for the quiet days? And that will give us a lot more detailed data, is what are we actually doing. Now, when we look at the studies for vertigo that we do, we have that granularity in the questions that we ask, what we call definite vertigo days and minor vertigo days, and and in normal days, which in tinnitus we haven't had before, partly because these questionnaires were developed a while back, and they were great for the time, but I think now with a new understanding, we need more granular data.
Right, right. Well, let's shift gears a bit and let's start talking about your work with migraine and medication specifically. Um, so this is where I'm ready to learn a lot. So in a recent study, you examined the use of nortriptyline, which I understand is commonly used for nerve pain, plus
Correct.
topiramate, which has many applications, as well as verapamil and paroxetine. So while there were anecdotal reports of inconsistent outcomes and some patients note worsening, which subgroups do you believe respond best to these medications? And additionally, how could you explain why certain patients might experience a decline in their condition?
Sure. So first, and during the clinical trial took a little bit longer for us to actually complete, because we hit COVID, and basically, our clinical practices were closed, and we actually couldn't do a lot of research activity during that time because they wanted to minimize patient visits and stuff. So we got a little bit delayed, but that delay allowed us to actually notice the patients when they're coming back. So there are fewer patients coming back at a time. And once we would then find out what they were on, and I could ask a little bit more detailed questions of them, um, we realized that the patients who had a fluctuating tinnitus, or we'll call an unstable tinnitus, where it reacts to various things quickly and makes it louder, those are the people that benefited the most, and the ones that had the change in baseline, or had a somatic type reaction where they press on their jaw or clench their jaw and they can change the tinnitus. Those are the patients that did the best. And so that's why, we concentrate on treating those patients a little bit more with this migraine regimen, because those are the ones that are going to have the best success. Now, clinical practice and clinical trial are kind of a little bit different, because in a clinical trial, you have to control for every potential factor that could be what we call a confounding factor, meaning that, um, you know, like there was a study that said, the number of tuberculosis cases was associated with the number of payphones in a certain area of the city. And so it has nothing to do with the payphone. It's just that it happens that poorer areas have more payphones. And so then, and they tend to live in a concentrated environment. So then they're more likely to get tuberculosis spread. So so we want to make sure we control every factor that we can possibly control. And that's the whole purpose of a clinical trial. And we want to isolate each factor so that we can see what is the effect of this specific factor. And my hope and goal with that trial of the drug combination was that, can we create a drug that then everybody can use, that would work in a large portion of patients, to make it easy for clinicians to treat patients? Because when I tell physicians, like, well, if you really want to treat this migraine related tinnitus, you got to control their sleep, their stress, their diet, overstimulation, hormonal changes. All these factors have to be corrected in order to correct the tinnitus. Plus you give the medicine, plus you give the supplements, plus you do cognitive behavioral therapy. It makes it too complicated. People are going to say, oh, that's too much. I just want a pill. Can I just take a pill or just prescribe a pill? And so that we're trying to see what the effect of just a pill alone would be. That's really what the clinical trial was. It doesn't take into account what we do in clinical practice, which is we kind of hit them from kind of all fronts. We not only correct the threshold related issue, which is what medications do, they change the threshold, but we also control the lifestyle, which is what creates the brain activity. So if someone's here, they're above the line, their tinnitus is very loud. In order to get them below the line, we could either raise the line, which is what medications do, or do lifestyle changes, which is what brings this down. Now, if you do both at the same time, you're going to have a much bigger effect, and much faster people are going to get better. Whereas if you do one at a time, you're going to see a smaller effect, which is what we've seen in our, in another study that we've done related to vertigo, which is caused by the same central sensitization process. So when we do each group, we just did lifestyle changes in one group, and one group got medications. This is a separate one from this trial that we'll talk about in a second. The effect was actually equal. They were about maybe 45 to 47%. But when we actually combine the two together, that's when we see a huge effect, and we see about close to 90% of people get better. And most of the studies we've done, the numbers are either 87%, 88%, or 89%. And so it's in that sort of general vicinity of 85 to 90% of people tend to see benefit. But if you were to isolate just medication alone, that's what this trial was about. And what we found was that the improvement that was seen in the patients in the drug groups was better than what was seen in the tinnitus group. Now, what accounts for people getting worse? I think, some people, there is some level of fluctuation to their tinnitus. And if in the same way that someone's taking a sugar pill, a placebo pill, and 30% of them get better, I specifically remember, like, one of the patients that came back in our trial, and he was we after the trial was finished, we came back at the 8-week time point, and we kind of unlock, sort of find out what he was on. He was on placebo. And he said, my tinnitus was really bad for the first 7 weeks, but this last week it felt better. So then when he answered the questionnaire, which is based on the last week, then he says that he was better. So there is some fluctuation that happens in people, and that is going to catch some people as worse, some people as better. So I think part of it is that. Part of it is the fact that some people are very sensitive to medications, which is very common in this central sensitization, where people are very sensitive to medications. So they take a dose that then gives them a side effect that, or causes something that then makes them feel worse. Now, there's a small percentage of patients that I've seen in my clinical practice who are very sensitive to serotonin. And serotonin is one of the molecules for communication in the brain, which some of these drugs act on and increase serotonin. And those people tend to have a little bit of increase in their tinnitus, in which case we have to use sometimes very small doses of the drug that we can't use in the clinical trial because it's a very set dose. We can't change the pill dose from person to patient. So in those people, like I'll use like pediatric doses of these drugs to kind of build up the tolerance of the brain, and then we can kind of get to the doses that are therapeutic. So there's things that I can do in clinical practice that I just cannot do in a clinical trial. And that's why we see a much better outcome in clinical practice than we do in clinical trial, because we're just isolating one component of this. But when we look at the overall, sort of patient groups who get these medications, it's actually very uncommon that people get worse, from the medication. I think the worsening, when I talk to them and they say, well, the medicine made me worse. And I say, well, what else was happening at that time? Well, I wasn't getting any sleep because, my baby was waking me up every night. Well, okay, your tinnitus worsening was because of the waking up at night every night, not probably from your medication. But it's hard to convince the patient. So we usually switch medicines, but with sort of reserving the right of, I tell them, I reserve the right to put you back on that medicine if we can't find another one that works for you, because this medicine works really well and I would rather use this. And I think it's just happenstance that you had another factor that made your tinnitus worse. But one thing I forgot to mention, nobody gets a permanent change in their tinnitus from these medications. So some people say, well, what if my tinnitus gets worse? Nothing. You just stop the medicine and the effect of that tinnitus will settle down within a day or two. So that, I've never seen it, and I've, treated thousands of people with this medication regimen. We've never had somebody who permanently worsens from it. If their tinnitus is worsening, there is another cause for it, not a one-time medication or a one-time vaccine or things like that.
Mm-hmm. So you kind of touched on elements of this next question, which is a question about the fact that you hold a patent on this combination of nortriptyline and topiramate. So how does a patented formulation differ from prescribing these two medications separately on an off-label basis?
Yeah, so the reason we picked the dosages for that, I should just to clarify, the patent's technically owned by the University of California, not technically by me. I'm an inventor of it, but University of California really owns it. We wanted to have a sort of a lower dose that what is commercially available to reduce the likelihood of somebody having the sensitivity issue, and to try to create the ratio between the nortriptyline and topiramate that we want to see ideally for people. And I wanted something that could be easy for, an ENT or a neurologist or a primary care doctor to prescribe. So that was sort of the goal behind it. Can people use it off-label? Yes, and that's what we do when we're not doing clinical trials, is we use sort of the off-label, medication. But, as I said, we tailor it to each patient differently. Some people who say, I'm very sensitive, we might start the nortriptyline at 1 milligram or 2 milligrams, whereas the which comes in a liquid version, but pills come in 10 and 25s, and topiramate comes at 25s, but you can get some 15s, and you can kind of cut the pill in half or sometimes a quarter. It's a really small pill. So there are ways around these things when we use even the commercial versions of these. It's just, it requires experience to sort of know how to handle these things, which I was hoping that we can create a combo drug that can then hopefully at some point get to market and people can prescribe, so that it would just be a pill, and it would take the need for all the experience that I have in treating this out from the average ENT who's going to be prescribing this.
So something like a one size fits most, but the individual differences may in a very interactive doctor-patient relationship, there may be some variation in the ratio.
Correct,
Mhm,
correct,
mhm.
exactly. And I foresee, even if I'm prescribing that combo pill in the future, that in some people we would maybe supplement it with a little bit more of the nortriptyline or more of the topiramate, because they may need a little bit different balance of that ratio that we think is one size fits most, as you said.
Mhm, mhm. Okay, so earlier you dropped CGRP, calcitonin gene-related peptide, uh, a couple times, and I'm curious to learn more about it myself. So there's this question about it. Given your view that tinnitus and migraine may share similar mechanisms, can you share your thoughts on exploring CGRP antagonists or other migraine preventatives for tinnitus?
Yeah. So we actually, that's an area of interest for me too. We've actually explored looking at CGRP antagonists as a medication for tinnitus. The the main problem, at least in the United States currently, is that these medicines are very expensive. So each kind of injection is about $800 to $900. So it costs about $800 to $900 a month. These are the antibodies, I should say, the antagonists, which are the blockers, which are the pills. Um, each pill is about a hundred and I think $10 or something, and you have to take it every other day. So you take 16 pills a month, approximately 15 to 16. So the cost of it is about $1,500 a month. So it's very cost prohibitive. It's not a trial that we could afford to run. Even the nortriptyline topiramate combo drug, because we have to have it custom made, that even that's kind of expensive, but this would be just way more expensive than we could ever afford to do with any kind of grant funding. So this would have to be an industry sponsored project. Those are somewhat complex to do because the company that makes those drugs has to have an interest in doing that and promoting it for that purposes, because it costs them a lot of money too. So we we haven't done it yet. It is something that I'm interested in doing. We sometimes use CGRP antagonists for patients who are very sensitive to everything we give them, medication-wise. And it does work for some people. But because we haven't used it, in, you know, hundreds of patients, I can't really give you great data yet, in terms of, how well it works in a larger group. But anecdotally, I can tell you that it does work for some patients when we use it, when we've failed other medications, partly because of sensitivity to the medicines. There are other ways of doing this, though, too. I mean, there are CGRP levels can be reduced in other ways. A lot of it is really the prevention side. And so what we do is we try to reduce the central sensitivity, which is what drives the trigeminal nerve to produce the CGRP that creates a lot of the symptoms. So that's using, other pharmacologic tools. We use cognitive behavioral therapy, and then it's sort of internet-based cognitive behavioral therapy that's targeting this central sensitivity or migraine. We use lifestyle interventions like correcting sleep and stress and diet and all that other stuff. So, you know, is there ever going to be a single pill or a single type of medicine that's going to fix tinnitus? I hope so. I really doubt that that would be the case, because I think it's a very complex brain condition. And, you look at migraine, there are like 30 some drugs you can use for migraine. Why are there 30 some drugs? Because nothing works for everyone. So each medicine works for only a portion of the patient population. And so complex disorders will need complex treatments. And those complex treatments require a multimodal approach, dealing with the triggers and then correcting the brain phenomena that cause the symptoms.
Mhm. Wow, that what an eye opener. Just curious, what types of patients, like generally speaking, go on this CGRP protocol that you described? That sounds not ideal.
Yeah, the CGRP drugs, I mean, right now, the insurance requirements are people have to have at least 15 days of headaches per month, and they have to have failed at least two medications.
Mhm.
Um, you know, eh, Part of that, the reason we don't have to use it much is because most people get better after two medicines. And if they're not getting better, we really delve into what are they doing in their life that is causing the tinnitus to be sort of more sustained, or the central sensitization to be sustained. You know, we really lock in onto their sleep because that's a very critical factor. So we get a sleep study potentially. We would send them to a sleep specialist to treat if they have insomnia. If they have in men, mostly a urology related issue, we send them to a urologist. So we'll try to fix the factors rather than throw more and more medications. But generally, patients who get CGRP currently in the United States is FDA approved for more than 15 days of headaches per month, and has failed at least two medications. The um, the the blockers, the receptor blockers, which are the pills, those can be used on an as needed kind of basis, meaning if they get a bad headache, they can take it. And we have used it for patients who would have a bad day of their tinnitus, that they take it so that it prevents it from becoming a multi-day loud tinnitus and try to kind of abort the tinnitus. But because it's so expensive and it's hard to get insurance approval, we use other means of doing this.
You did touch on earlier you said it's very rare that patients get worse from these medications, but this is a common question. You see it pretty much in any field, definitely with how tinnitus patients can get knowledgeable about the subject. We still have this question. Many patients report experiencing notable side effects from medications such as SSRIs, tricyclics, or topiramate, and some feel their tinnitus worsens. How do you balance these potential risks and benefits? And is there any method to predict who might tolerate these drugs more successfully?
Sure. So I should sort of first say is that sensitivity to medications is actually very common in this central sensitization. I mean, it's part of the name. The brain's very sensitive, and so and sometimes I I'm talking to the patients, and I tell them, so we use medications to treat this, and then they say, well, I want to tell you something, and then before they say it, I say, let me guess. You're going to say you're very sensitive to medications. And they say, yes, how did you know? They get very scared. And I say, because this is a very common thing. This is actually very common in this problem. We see it in tinnitus, we see it in vertigo, we see it in other forms of migraine. People are sensitive to medications because the brain's amplifying, the activity that the medication causes. So we have to use much lower doses of these medicines, and that's part of that combination medicine that we develop. It's lower than the typical doses that are available. And so if you go to let's say an average neurologist or primary care doctor or an ENT, some of them who would prescribe medications, let's say, for this purpose, they usually, let's say for nortriptyline, will most commonly use 25 milligrams. And I can tell you that if you give 25 milligrams to people with, because that's what the original paper back in the 1990s was written about that. Um, so, but if you give that, a lot of people are going to get side effects. But that doesn't mean that medicine's not going to work. It doesn't mean that is going to create problems for the patient. It just means that they are just sensitive to the medication. So we oftentimes will start people at much lower doses, and we sort of slowly go up. But I should mention is that the other very critical and equally important part of this is the lifestyle changes that the patient has to make. And so if somebody comes in and says, I tell them this is not an a la carte menu. It's not like I'm going to just do this one. I'm just going to take the pill. I'm not going to do the sleep problem. I'm not going to do the diet. I'm just going to maybe go do some yoga and reduce my stress, but I'm not going to work on the other ones. It's not going to work. I tell them it's a prefix menu. You gotta do everything that's on there. And that includes, we got to fix your sleep. We got to fix your diet. You got to do all the other things that we tell you to do. And you got to do the medication together if you really want to get better. So sometimes people, they have a negative interaction with the drug potentially because the dosage or their sensitivity or something. And then they say, no medicine works for this. How could you be saying that medicine works for it? And I say, well, because if you're not doing the other component of this, your brain will continue to stay sensitive and the problem will continue. So we need to actually do both things if you really want to get better. And so sometimes they say, well, I've already taken nortriptyline and that didn't even work. And I say, well, how was your sleep back then? Were you following the diet? How was your stress? Were you doing, how was your hormonal changes, etc.? We'll go through those things because if you're not doing that, the drug's going to work less than half the time. Based on our own sort of experience of looking at just the drug alone, it's only about 45%. So, and in our trial, even with the combo, at sort of medium doses, it's only about 50 some percent. So the way to get better is to do both things together. The problem is lifestyle changes are hard to do. And so people have to be committed. And so, we see people who say, I did the treatment and it didn't work. Well, oftentimes I should tell you, those are people who didn't do the treatment. They only did it beginning of it and then they dropped out because it's a lot of work. You have to change the way you sleep. You have to change the way you eat. And these are actually very good things for the patient because those are the same things: improving sleep, reducing stress, improving diet, the sort of the low inflammatory diet, or which is low glutamate, tyramine, caffeine, histamine diet, which is what are the substances that involved with migraine processes and central sensitivity. That actually improves cognition. It lowers your risk of getting dementia, lowers your risk of, even like vitamin B2 that we use, lowers the risk of Parkinson's recently has been shown. So all of these actually are good for the brain. And the brain sensitivity is what creates a lot of these other symptoms, such as tinnitus, headache, fibromyalgia, chronic fatigue, IBS, irritable bowel syndrome, is due to central sensitivity. All of these factors that we're doing are actually good for people, but they are difficult to do. And I'm the first to admit that it's difficult to do. But if someone's determined to improve, they will get better. But to say that I just get a side effect from this and therefore this doesn't work, or, then I would say, well, if you're not doing all of it together, you're not going to get better. And we have to use lower doses. That's why it's kind of an art in terms of doing the medication regimen, because each patient has to get a different medicine to start. Each patient has to get a different dosage to start, based on kind of how much of a hurry they are to get better and what their general sensitivities are.
Mm-hmm. Well, that seems like a good lead into this next question, because I know everyone wants to know about neuromodulation devices. But and I'm right there with you. I was among the legions of tinnitus patients early on who just wanted a simple solution. I wanted to do the least amount of work. And even I wonder, will something like neuromodulation provide me the opportunity to not have to work on my tinnitus and just get better? So do you see a future in combining things like migraine-oriented medication protocols with such devices with neuromodulation?
Yes, definitely. I think, there are some neuromodulation devices that have potentially some central effects. I think the the Dr. Susan Shore device has some potential because it's probably stimulating through the neck and stimulating the trigeminal cervical regions. So I think, yes, I believe that the future is going to be probably a combination of things. That there may be devices that can provide some level of neuromodulation that will reduce some parts of this brain activity, and medications and lifestyle changes can be used for other components of this. But do I foresee a future where there is going to be something um, non-invasive that can completely make tinnitus kind of get better without the need to do any of the lifestyle changes? I think the only way I can see it uh, would be through, at least the only way we have achieved it, I should say, and others have, is through stimulating the inner ear, the cochlea, directly. And that's going to be an invasive, some kind of invasive procedure, meaning something has to go behind the eardrum to be right on the inner ear. That's going to provide a larger percentage of patients with improvement. We have stimulated the eardrum, similar to the initiative from Berlin, the University of Berlin. But we didn't find it to be as effective as when we did it behind the eardrum. We made an incision in the eardrum, passed the electrode through the eardrum, and stimulated the inner ear itself. So we think that that's sort of where the future is, and we'll be talking about that, I guess, a little later. But I think in terms of what I anticipate, I think a combination is probably where everything is probably going to go. And Professor de Ridder has talked about this war on tinnitus, where he says, when there's a war, you have the Air Force and the ground troops and the Navy, they're all working together. And when we're treating tinnitus, we kind of approach it from multiple different directions. We use the medications, we use the supplements, we use the diet, the sleep, the stress, etc. So you got to do all of it in order to get better. I hope there will be a device, I hope it will be our device, but I hope there will be a device, or at least multiple devices, at least hopefully maybe ours would be one of them, that can do it without the need for that. But I think really the best long-term solution would be probably a combination.
And I am excited to talk about your implant research, but there's some questions that might bridge what we were just talking about and the implant. Anything that takes a lot of work is going to take a lot of money. And some people have voiced concerns about the high cost of your protocol. I think there's a number on your website suggesting it could introduce bias into your research findings, that barrier to entry. So how would you address the critique that charging thousands of dollars for a still experimental approach may lead to a conflict of interest in how data are reported?
So first I should say is that our studies were all completed and most were published before there was a website. And the reason there is a website that's now treating this using my protocol that I've developed, from these clinical trials and treating thousands of patients is because we now saw that actually it works, and even in a controlled environment. So we aren't, it wasn't like we said, hey, we should start treating patients and charge a lot of money. And then while we're doing that, let's go and do the clinical trials to see if this thing works. And then try to potentially bias the clinical trial in a way that can make it appear like it's working. So, so first I should say we did all the data before we started actually implementing the treatment to give to patients because, at the end of the day, I want to make sure this thing works. And so I want to make sure that what we're seeing and observing in clinical practice is what basically is going to be something that's going to help people before we go through all this work to try to treat people across the country and the world. So first that, and second is research is really distinct from this, practice. The data that we produce in our research data all comes out of my clinic at the university or the studies that we do at the university. The data from the telemedicine clinic, the Neuromed care group, is that's sort of up to whatever they decide to do with it. But that's not what is getting published. So there, as far as bias, sort of it, um, anybody who comes up with a new idea is going to be the first one who's going to test it. So if I come up with a new idea of how to treat tinnitus, some random researcher in another place isn't going to say, "Oh, I should go and test that," before he does it himself. So I will always be, whoever the inventor is, whoever the sort of the person is who comes up with a new idea, is going to be the first one who wants to test it themselves. And I think, people may not realize the how critical one's sort of reputation is in academia, and how if somebody were to be in academia, I could tell you they would never ask a question like this, because nobody in academia would throw away their entire reputation for, money that would be coming from, let's say, something like this. So, uh, you know, at the end of the day, if you don't trust the data, then, don't get the treatment. Go somewhere else. But if you are going to treat it, you have to trust the work that was done before the clinic was established. All this work, all the research. Just go look at my papers. We've published 30 papers on tinnitus. All of this was done before this. I started working with this clinic in order to implement our research and how successful it was into this. So, it would basically, if we're going to question bias, then we can't trust anything anybody does, because at the end of the day, let's say the data that, for example, Dr. Shore's device, she's done several studies, great studies, very well controlled, and they showed. But am I going to say that she's only, she's biased because she wants to make money? No, I would never say that, because she's not going to throw away 30, 40 years of reputation of great academic work for this money for this. Someone in academia wouldn't do something like this. But I can see how someone outside of academics can see this, could potentially think that that's the case. And there is sort of this way of sometimes thinking that people in academia who do research and stuff are sort of in a kind of, they're elites or something, and they're just trying to out for themselves and trying to make money. Honestly, if you were in the environment that I'm in, and you go to the meetings that I go to, everyone is actually trying to do their best to try to help people. That's sort of the primary goal. You know, until this clinic was established, I had no. Why did I do tinnitus research for 30 years? It wasn't just suddenly to have this associated with the clinic. It was really, I'm trying to find a way to help a lot of people with tinnitus. If you think I'm going to throw away my reputation because of this, then that's sort of your opinion. That's totally fine with me. But keep in mind, in the United States, there's sort of two systems, basically. It's different than it is in Europe. And I should tell you that people in California don't even question something like this, because this is actually very common in California, where a lot people who do very specialized care don't accept insurance, and it's out of pocket. So if you want sort of an out of pocket investment into a cutting edge treatment, that's what you have to do. But if you want insurance to cover it, insurance is not going to do it right away. And insurance doesn't allow the kind of treatment that is necessary to get people better with tinnitus. And that is, what I found in my practice is the patients who had sort of the somehow were I had the closest connection to, and they could easily contact me, that those people get better much better and much faster, because I can make small adjustments as we go, rather than the normal, which is I see them and then I see them 3 months later after they've tried the medication. But so if we want to have, and I can't do that for everyone, obviously, because there's only one of me and there are thousands of patients, but there are just some who are friends or whatever, and they just knew me. They could ask me questions, every week if they wanted to. Now, so then what I realized is that for people to get better, and that's why I talked to the clinic, is that you need to provide unlimited access to the provider. Now, if you were to go to a neurologist and say, I want unlimited access to you, I want to be able to email you anytime I want, and I want you to respond within 24 hours with great detail, and I want you to send the medication for me, they will laugh at you, because no one has that kind of time. That time spent by physician is uncompensated. And so if people are going to do that for everybody, basically they will be sending emails all day without seeing patients, and then they will go bankrupt. So for this model to work, because insurance doesn't pay for email, insurance doesn't pay for all these other work that's done outside of the visit. So insurance says, visit this many minutes, this is how much you get paid. But if I want to continuously be in touch with my doctor, then doctor is going to say, well, there's an extra charge for that, and then you have to pay outside of your insurance for that kind of access. That's what this clinic does. They have health coaches. They have people who work on the diet. They'll meet with the patient every week. They have access to this cognitive behavioral therapy and the customized sound therapy that we developed. It's all part of a comprehensive treatment package. If you actually compare this to other types of treatment rehabilitation, it includes things like outpatient drug rehabilitation, chronic pain rehabilitation. Those are also out of pocket and thousands of dollars. If you look at sound therapy, you go for sound therapy to an audiologist, or there's some online companies that do this. It's $5,000 for what these sound generators. If you want to know, those sound generators cost $29. So you're getting $29 devices, but you're paying $4,930 or $70 for their time, for the audiologist to spend time with you and to try to help you as they go along. That's what you're actually paying for. That's why treatment costs a lot of money, because it's a high touch point treatment. It requires patients to be the providers to be very involved in the care, and for the patients to have easy access to the providers. That's the only way that unfortunately can work in the United States. I know it's different in Europe. Maybe the European system does, because it's a national health system, may be different. But in the U.S., unfortunately, tinnitus isn't considered a major issue. So the insurances don't cover tinnitus treatments, unfortunately. So you look at the linear device, that's a $5,000 to $6,000 device. What are you paying for? Are you paying for the device, or are you paying for the time of the audiologist to make corrections for you every time you want it? Most of the money you're paying for that device is actually paying for the audiologist's time. Almost just about a little bit over the third, or a little less than a third, depending on how much you're paying, is actually paying for the actual device. Most of the money you're paying is for the time of the care provider with whom you have unlimited kind of access. So that's just the model. Unfortunately, it costs money. Is it going to be something that's going to bias our studies? Not at all. We've published our studies. If I wanted to bias the study, I would say nortriptyline topiramate works in 99% of people, and the placebo works in 0%. But the way we do studies, it's what we call triple blind. So meaning I don't know what the medication is that the patient's getting. I don't know if they're getting a sugar pill or not, or they're getting the pill. The patient doesn't know, and the person who does the analysis doesn't know who is in which group. This way we have no way of introducing bias. And if you look at our data, it's like 54% in one group, 71%, and the placebo had 30% people who got better. So if I wanted to introduce bias, I would make that placebo number look a lot smaller so that it makes my other numbers more impressive. But we just present whatever data the data gives to us. We're not going to massage the data to create the appearance that something works better than that, because it's not worth it to me. Still, my primary job is to take care of patients, do surgeries, which half the time I spend doing surgeries, which has nothing to do with tinnitus. And, I do clinical research and basic science research, and I have 10 or 15 different large projects that I'm working on, tinnitus being one part of the whole package. So, that's all I can say about this question. I don't know if that answers the question or not, but I'm hoping that it did.
I feel like that's pretty comprehensive. And just again, from a patient perspective, like, so often as someone in the United States, anytime something's wrong with us, the first thing we look up is how much will it cost to fix this? And that's a huge factor in whether or not we're willing to seek treatment, which, that's a much bigger problem to talk about. But I think it's worth addressing, and to hear it from the doctor himself is, I think, very valuable. But speaking of migraine symptoms, I got some sunlight coming in here, and I got this like glowing aura. So I don't know. Hold on. If you'll just give me a second, I can block it.
Sure.
Yeah, sorry, it's pretty distracting. I can't even see myself.
My migraine gets triggered by bright light. So, I've had tinnitus multiple times, but I recognized what triggered it right away and fixed it so that it didn't become chronic. Although it's kind of been sometimes a worry of mine that sometimes it was going to get out of control and it might become chronic. So, but I'm very careful. I pretty much follow everything I tell patients myself. The only thing I probably don't follow is, I have a lot of stress. I have a very stressful job, and running all these research projects and finding funding for all these research projects and being responsible for the 20-some people that I have to, be able to find a way to pay. That's stressful. So it's a lot of work, but I think it's worthwhile because I think I'm doing something good for humanity. I'm hoping.
All right. Wow, so much. Sun setting at 4 o'clock here in New England, and going through my basement window. Well, so you touched on a lot of the points in this success rates and outcome tracking question that was submitted, and I want to give it the airtime it deserves. I have my own follow-up question, so I'm gonna say a lot all at once, and you can assess whether or not you feel like these smaller points need further addressing, and then I'll sneak in my own question. Um, do you systematically track and publish quantitative data regarding patient outcomes, including the proportion of individuals who experience significant improvement, partial improvement, or no change? And then it goes on. In your experience, what percentage of patients achieve clinically meaningful benefits, and do you rely solely on TFI improvement as the metric? Now, I have my own sub question, if it's not too much to throw at you all at once, which is, how do patient outcomes shape the future development of your research and protocols?
So, great questions. So first is, do I systematically track and publish quantitative data? So yes, we do our best to get data from patients every time they visit. Sometimes the patients are doing video visits, and so we have to send them a link to our questionnaire to fill out, and they don't always do it. So, uh, we're trying to systematically do it on everybody. Not everybody speaks English, so not everyone can do the questionnaires. But we try to do it as much as we can, and we're doing that so we can publish, and we do extract data out of our sort of database to publish studies on subsections of people. So yes, that's the goal, and we're trying to do that over time. the what percentage achieve. So first, as I should say, is the percent that achieves clinically meaningful benefit is the right patient group. So the right patient group is people with the so we'll call the migraine phenotype, or the central sensitization phenotype of tinnitus. Um, and that's one of the things that we've learned from, is to address your last question, is um, as patients reported things and we try to delve into, what were the characteristics of the patients who had the best response, we found that the ones with fluctuation, the ones with the change in baseline somatic tinnitus, those are the ones that responded the best. Those who have a combination of tinnitus and like the atypical symptoms like neck stiffness or ear pressure or sinus pressure, etc. Intermittent tinnitus patients, those are the ones that do the best with a treatment regimen that we do. Now, do we rely solely on TFI? I mean, when I'm talking to the patient, I just ask them, on a scale of 0 to 10, how's your tinnitus on average? And, are you happy? We get the data from them. They fill out the iPad and stuff. So when we report it, it's using the TFI. But just, when I'm talking to them and I record it in the chart, I'm really just going based on the first question of the tinnitus, of the combination of the first and second question of the TFI. So it is, as I said, it's the best tool we have, despite its limitations. I think there will be biomarkers that will improve that tracking. Um, you know, so yes, we are using it. That's really, I think, the best thing we have. That, the THI, the Tinnitus Handicap Inventory, is another tool. We also get data. We've actually started to get data on some of our patients with both the THI and TFI to actually look at correlations. But one of the issues I have with the THI is that THI, you're a little bit in danger of creating the appearance of improvement when there may not necessarily be a clinically meaningful improvement. So when we look at clinical research on using surveys, we look at what's the minimum clinically important difference. And the TFI, both of these scales are 0 to 100, TFI and THI. But for THI, the minimal clinically important difference is only 6. I personally don't think that if somebody goes from, a 90, to an 84, they've made a meaningful difference, and we've made a meaningful difference in their tinnitus. I would actually consider that variability. I think, the TFI, the minimal clinically important difference is 13. So it seems a little bit more substantial. So it's the best tools we have currently is surveys. We used to, on some of our, if you look at some of our trials we did for sound therapy and stuff, we did use minimum masking level and tinnitus matching, and we showed that the minimum masking level mirrored the same sort of improvements that we saw on the questionnaires. Doing minimum masking level is very time consuming and labor intensive. So it, the survey is a lot easier and faster to do. It adds easily another 30 minutes to the patient's visit to do that. And, it's just, could we do it? Yes, we could. I mean, is it going to give us more data than the TFI? I don't think so, at least based on our previous experience doing it. When we've done smaller trials, we've used it. But, if we're going to run through 100 patients, that's also a lot of time that we have to use up our audiology booth, which is also used clinically in our clinic too. So we haven't for the larger trials, but for the small trials, we have done it.
So, and thank you for that. And I realize I snuck in my own question there, but so I guess I'm curious, given that they're like each of these cases going to have so much uniqueness, so many variables, I'm curious how you're able to take that patient feedback or those patient outcomes and use them to shape how your research proceeds in the future or the development of future protocols.
Yeah. So what we look at is what do we, when we look at our trials, and we're actually publishing another paper on it, is looking at sort of who are the people who actually got the benefit and what was different about them, and how did they escalate the dose? Because there's some people, and part of the reason we found that the nortriptyline topiramate group didn't do as well as the verapamil paroxetine, even though in our clinical setting we see that the nortriptyline topiramate works better, is we noticed that people with nortriptyline topiramate got better at a lower dose initially on the when we saw them, and because they would get a call once a week to see how they're doing, and then they would be instructed to increase the drug or not. So, or whatever they're taking. So even if they're taking the placebo, they would be told to increase it or decrease it. But so what we found is the ones who got better earlier, they tended to not go up as much on the drug, so that they didn't finish the course of the drug at 8 pills, which is what our goal was for everyone. So that may have been. So we look at the data to try to see who improved and why did they improve. Is there something characteristic about these people that made it improve, whereas the other ones didn't? I mean, in terms of what we see clinically, and what patients report, I can tell you that universally, if someone's on 2 drugs and they're not better, there is some major trigger that is not being improved. So either it's a dietary trigger or a sleep trigger or a stress trigger, most commonly. And so we need to correct those. If we don't correct them, then we're not going to see the full effect of the drug. But yes, we are continually doing it. I mean, that's what clinical research is continually looking at patients as we're coming through, treating them and getting data on them to try to understand what we can do that can improve the treatment regimen so that more and more people can benefit from it.
Thank you. Well, so this next one kind of touches on a lot of the sort of what it takes to get those patients in your office in the first place, and not just your office, but anyone's office, and sort of reflects the patient experience of, like, sometimes there's disappointment, but I'll let the question speak for itself. Your website and materials often emphasize that tinnitus is fully treatable and cite a high success rate. However, feedback in online forums and community discussions indicates that some individuals see minimal or no benefit. Do you believe the current messaging accurately reflects both the potential limitations of your protocol and its success probabilities?
So I should emphasize, the question isn't, I don't know, doesn't take into account what we're actually saying on the website at all. So the website says, and if it doesn't, let me know. I'll tell the people who run the website to make the corrections. But what we say and what I have always said to patients, to every talk I give, is we're talking about treatable, not curable. And when we talk about treatable means reducing the volume. So it's not bothersome. That's what the treatment achieves. And, at least in my practice, because I don't see the patients who are coming through the website, I've just taught the people who do the treatment on the website, and they do the treatment, and I'll help troubleshoot things for them. But in general, I can only speak from my own experience of treating my patients, because that's how they treat it. Although they get much better treatment at that website, because patients have unlimited access and they have all these health coaches who help them through the diet and all this stuff that I really can't do for the patients in my own practice. But what I tell them is, you have fluctuation, you have some really bad days where it's intolerable and takes over your whole life and you can't work those days or you can't do anything. And there are some days that you're quiet. The only thing we can achieve is get your bad days to all be good days, or minimize the bad days. And if you do have a bad day, you'll be able to recognize what caused it to be bad. And then you can correct that for the next time. So then you don't get another one. That's what the process is. Or if somebody had a low baseline tinnitus and it suddenly has become loud after a certain event or whatever, we can get you back to your baseline tinnitus. We can't make it go away. So it's not a cure. So treatment is not equal cure. I want to make sure that it's that's clear to everyone, and it should be very clear on the website that this is what we're talking about. Now, the high success rate depends on patients actually finishing the program. A lot of people are looking for a quick fix. That's why, if you're on social media, you'll get bombarded by these eardrops and supplements and whatnot as a quick fix for tinnitus. And because that's what everybody wants. I mean, that's what I would like to be able to have for tinnitus. I don't think it's going to be that easy because it's a complex condition. It requires work on the part of the patient. A lot of people will start the program and say, this is not for me, or I don't want to take the medication. I just want to take the supplements and get better. Well, it's not going to work. You got to do the full deal. If you want to get better, you have to do everything. And I can tell you, if somebody does everything, it's uncommon that they don't get improvement. I mean, just as I said, having treated thousands of people, the people who don't get better are usually either they didn't take the medication, or they stopped the medication, or they don't want to give up their caffeine. They want to stay up until 3 a.m. on a weekend, and then wake up early on a weekday and go to bed at 10, and have this highly variable sleep schedule. They don't want to get treatment for their sleep apnea. They don't want to treat their insomnia. Well, you're not going to get better. I wish there was an easier way, but the only way to get better is we got to fix every aspect of your life that's causing the tinnitus to get worse. So, and online discussion groups tend to amplify sort of the unhappy opinion. And, I can tell you that from what I understand is the people tend to be the people who haven't finished the program and sort of opted out early. In my last 20 years, I've seen probably close to 100,000 patient visits, and this is not just tinnitus or all sorts of ear problems that I deal with. But if you look at my reviews online, let's say, there's a website that has 4 reviews of me. Are those 4 people representative of the at least 30,000 different people I've seen in the last 20 years? Probably not. But are those people were the ones who happen to become very angry for some reason? Yes. And interestingly, sometimes I look at these reviews. These people some of them never even saw me. They called, they couldn't get an appointment because it took 6 months, and they were unhappy with that. Did they go and post a bad review? So, so I just always caution people of looking at a small sample of strong opinions that tend to be more negative in an online forum, especially when it's in an anonymous forum. If people would attach their name and face and say, I did the full program, I did the diet, my sleep was perfect, my stress was reduced, I completed the cognitive behavioral therapy like I was supposed to, I took the medications like I was supposed to, I did all that stuff, and I didn't get better, then I will accept that. That's no problem. But if someone comes in with, some random username, no face attached to it, and says, I did it and it didn't work, and they never even took the medicine, they never wanted to give up their coffee, they never wanted to give up their, wine, well, I don't expect them to get better. I would be surprised if they got better, in fact. So it takes work, but if someone is determined to get better, and they're going to do the things that we tell them, it is uncommon that they don't get better with what we do.
Takes a lot of work.
Yes, exactly. So now let's go talk about quick fixes.
Yeah. And I think often about the relationship between a quick fix. Once it is the quick fix, it's often the result of a lot of work on the other end. I think of like a seesaw or a fulcrum, and this seems like a lot of work, hopefully resulting in our dream scenario of a quick fix. So let's talk about your middle ear implants. So you've explored the concept of a middle ear implant specifically for tinnitus. How does this approach differ from standard cochlear implants or other electrical stimulation devices? What is the rationale for targeting the middle ear rather than focusing on cochlear level stimulation?
Great. Yeah, great question. So, um, a cochlear implant is a device, just for the background, is a device that's used to restore hearing for people who have severe or profound hearing loss, or they're deaf basically, or have unusable hearing. Um, it is a device I do tens of times a year. I've done probably 700-800 of them in my career. So it's a procedure we do very commonly. We're placing an electrode inside the inner ear. The inner ear is the so-called cochlea inside the hearing organ. It goes inside that sort of snail-shaped organ. That's what then stimulates the nerve inside there, because you need accurate stimulation and different regions to be able to get the stimulation you need to be able to understand speech. Our device sits outside the outer wall of the cochlea, outer wall of the inner ear hearing organ. And the outer wall of the hearing organ has a small membrane called a round window membrane. And that round window membrane is where our device sits, right at that edge. A cochlear implant, in the surgery, we actually make a hole in that membrane and place the electrode inside the inner ear. This sits on the outside of the inner ear. So it's technically sitting inside the middle ear, but it's actually stimulating the inner ear. So that's how it differs. But it's sitting on the outside of the inner ear, so it's not going to provide the detailed level of stimulation a cochlear implant can to provide speech, but it's enough to stimulate the nerves, at least in the high frequency region of the inner ear, which can then provide stimulation at the brain level, which can then quiet down some of that activity, which is what is triggering tinnitus in our thought process. So technically, we're not doing a middle ear stimulation. We're placing it in the middle ear for stimulation of the inner ear, or cochlear stimulation. So we are stimulating the cochlea. We're just not stimulating the cochlea from inside the cochlea. So that's just really what it sort of comes down to. So I hope that sort of answers the question. It's because if you were to place a device inside the cochlea, then there is a chance you can actually become deaf from that. Because once you open the cochlea, you can get leakage of fluid, or you get inflammation in the cochlea, and you can lose your hearing. But when you're doing a cochlear implant, they already have pretty poor hearing. Even though we're able to preserve hearing in a majority of patients, that hearing slowly will diminish over the next 5 to 10 years. Whereas people who have tinnitus oftentimes have normal or near normal hearing. So we don't want them to lose hearing, so that's why we have to place it there.
Mm-hmm, mm-hmm. So then that leads us to the next question, which is about the mechanism. How does it work? If tinnitus is primarily driven by central mechanisms, how might stimulating the middle ear or cochlea, I guess indirectly, effectively reduce it? Do you view the reduction as a form of residual inhibition, or is there deeper neuroplastic process at work?
Yeah, great question. So I think the neuroplasticity comes with chronic stimulation. I don't think it's going to occur from the short-term stimulation that we were doing, that we did initially, in order to further then develop this middle ear implant. So tinnitus is driven by a central mechanism. There are two components of it: the production of the sound, which is that basically increase in the spontaneous firing rate at the various portions in the auditory cortex and the cochlear, dorsal cochlear nucleus, etc. That's driven by initial hearing loss. So loss of hearing cells at the cochlear level cause that increase in spontaneous activity in the brain. That's what creates the tinnitus to begin with. That sound is actually there in a lot of people who don't even hear their tinnitus. So just as a quick background, when they've taken like undergraduate students who have very good hearing, they're 18, 19, 20-year-olds, and they gave them an earplug for 1 week, 78% of them developed tinnitus in that ear. It's no permanent damage actually occurred to their ear. It was just blocking outside sound, and so then the internal sound became more audible. So that tinnitus activity was there. It's just because they weren't hearing outside sound, it just lost the masking ability. You're hearing it. They took the earplugs out, and all of them, the tinnitus went away. So tinnitus is a central process that's there all the time due to a drop in activity that's coming from the auditory nerve, from the inner ear to the brain. If you can increase that activity from the inner ear to the brain, then you can quiet down that central mechanism. Now, that mechanism can be driven because the neurons that are in the cochlea, they're called the spiral ganglion cells. The spiral ganglion cells will live for many years after, even if you have your entire hearing wiped out. If you were to, let's say, I don't know, have something ototoxic, or go to a war and there's a blast that sort of destroys your hearing, you will still have the neurons for at least 15 to 20 years later. That's why a cochlear implant works, because those neurons are still alive, even though you've lost a lot of hair cells. So what we're doing is we're stimulating that neuron in the absence of the hair cells, basically. The ones that are not getting input from the hair cells, we're stimulating with electric stimulation. Now, as I mentioned, there are two systems. One is driven by the loss of cells, which is what our device is going to be doing, hopefully. The second is the brain's attention to that sound signal. And that attention to sound signal is what separates the people who have loud, bothersome tinnitus from the quiet, non-bothersome tinnitus from the people who don't hear it, who actually still have the tinnitus activity in the brain. So those are those undergrads who, they had tinnitus. It was there. It just was covered up because there's background outside masking. Once you block their hearing, then they develop tinnitus, but that's reversible because the central sensitivity process has not become active to continually concentrate on it. It doesn't become part of the salience network, which makes the brain prioritize it as being an important information. So I think that's what's sort of the difference between probably the sort of three groups. But all three groups are triggered by a loss of input from the periphery, from the neurons of the inner ear. And that's what our device is intending to do.
So could you explain the device itself and like how it's positioned, powered, and activated, and like what the patient
Sure.
experience might be like?
Yeah. The device that we envision, and we've built components of it, but, we've sort of have a benchtop sort of model of it, but haven't placed it in anybody yet, I should mention, and that we hope that we would be able to place it in somebody within hopefully about a year and a half, maybe. That's sort of our goal. So the device has three components. There is an outside component that's basically like a handheld programmer that the patient can use to turn it on and off. And the audiologist was used to program the device. There's a component that goes in the ear that then drives the signal and the power to the internal device. So the internal device is powered through coils, just like a cochlear implant. Basically, there's no implanted battery. So you have a coil on the inside, you have a coil on the outside. If you get them close enough and lined up well enough, then if you drive an electron through this, drive power through this one, you're going to drive an electron through the other one, through this sort of coupling that happens. And that's sort of what our device is, how it's going to be powered. So it will require a small surgery. It's a surgery that if it's an ear specialist, they could do in the office even. It's probably a 15-minute at most surgery. If it's somebody who doesn't do a lot of ear surgery, they'll probably have to do it in the operating room, so it's a little bit more controlled. And then once everything heals, then they would get the outside portion of the device that would have to be customized to them. And then they get the handheld part, which then would be programmed by the audiologist.
What is that outside part like? Does it hang over the ear or something like that?
Yeah, good question. We haven't made the one that would be kind of human ready, but at least as a first step, our first iteration of it will be much bigger. It will probably be in the size of like a little box that's going to be like a headband and have a part that goes in the ear. But eventually, it's going to look like a hearing aid.
Mm-hmm. Interesting. Interesting. That'll be really cool. I mean, is it too early to ask, like, what if down the line, or even if the patient presently requires the use of a hearing aid, would there be like space on their head for both devices?
Potentially, yeah. I mean, if they have all we need really in the ear canal is the coil, to be able to transfer the signal and the power. So in in the future, it may become a component of their hearing aid that would just get added onto their hearing
Hmm.
aid that it would kind of snap on, and could then potentially be, um, you know, doing all the things that we needed to do. But you know, I, it's a great question, and you know, they may need, in terms of where the uh, body of it would be, either it would be combined with the hearing aid potentially for some people, or it would be a separate little thing that they'll have on their
Mm,
ear, kind of that could maybe snap onto their hearing aid.
pretty cool. So you mentioned that you're hoping that within the next year and a half you might see some actual trials. Do you anticipate there being uh, trials being conducted at multiple facilities or like collaborations with other researchers? And how do you plan to measure efficacy?
Yeah, so initially, we'll probably have the trial internally until we kind of make sure we figure out all of the issues that need to potentially be corrected for a second phase of the trial. That's when we would open it to other centers. Um, you know, uh, I should maybe sort of tell people doing clinical trials is extremely expensive. And if you want to do a clinical trial that's in a multi-site clinical trial, if you have, let's say, one site and then you add the two other sites, the cost does not just go up 3 times. The cost will go up like 5 to 6 times because there are a lot of other things you need to do when you have a multi-site study. You need to have somebody who goes and trains people there. Somebody has to go there for the first procedures. Like I would have to get up and go there. Like it's not as trivial as a pill may be a little easier to do. Um, uh, but a device, especially when it requires surgery, it's a little bit more involved, and there are a lot more regulations from the FDA standpoint. So, yeah, it's an expensive endeavor to do a multi-site, and you know, this money's got to come from somewhere. It's these things are not easy to fund. I mean, just getting an idea like this funded is incredibly difficult. And had it not been really the vision that Brian Fargo had, and the other patients of ours have supported, and some foundations that have been supporting this, we wouldn't be where we are, because the national funding agencies don't fund on new ideas at this level. For you to build a device, it's a couple $1 million process, and they're not going to give a grant for something they don't know is going to work until they like really really sure. So you have to almost build the device, test it, and they'll say, okay, we'll give you money for the next phase of it. So maybe once we're able to do our first stage of the trial, the first phase, then we'll do a multi-institutional study. We'll probably be able to hopefully get a larger NIH grant if the NIH budget doesn't get cut, significantly with the new administration. But hopefully, if and maybe at some point there may be a commercial interest that maybe want to potentially invest in and be able to do those larger studies that require a lot more money than we could ever get through a grant process.
Mhm.
So, how are we going to measure this? You know, the measurements are going to be the standard systems, which the way we measure tinnitus for these trials, because this is a continually changing thing. When you're electrically stimulating, the first few minutes, sometimes there's no change, and then suddenly there's a drop. Um, and I've always sort of, I should say, I've sometimes laughed at these trials um, where the patient got stimulated for 1 hour electrically, and then they're doing a TFI on the patient before and after. Um, it makes absolutely no sense because the TFI is the questions are all over the past week. How has your tinnitus been? Someone's tinnitus isn't going to change within 1 hour, and then they're going to have a difference in the TFI. It's now, if someone's going to get stimulated over several weeks, then you could do a TFI. But what we do is subjectively a 0 to 10 level tinnitus, and then what we anticipate is that we would do loudness matching, minimum masking level, etc. TFI and THI, or when the tinnitus has been there and the treatment's been there a long time, it doesn't work for a 1 hour, 2 hour, 3 hour stimulation. It's got to be weeks of treatment in order to do a TFI, THI.
Well, I mean, you brought up the TFI, and there's a little follow-up question in that question, which is, what are your thoughts on the feasibility of using those subjective measurements, such as the TFI, in tinnitus research, I think in general?
Tinnitus is a subjective phenomenon. My experience with tinnitus is way different than your experience with tinnitus. And we may have the same level of tinnitus. So if you do, let's say, a minimum masking level or a tinnitus match, we might have a 2 decibel tinnitus. Both of us have a 2 decibel tinnitus. But for you, that's a 9 out of 10. But for me, that might be a 1 out of 10. So I think when we look at tinnitus and what the outcome is, we want to, at the end of the day, we want to make sure the patient is happy, that the patient had a reduction in the sound. That is best achieved by asking the patient. Now, what we do in our electric stimulation trials, and we will be doing in the future, and has been done in other kind of studies, is what's called a sham stimulation. Basically, we tell the patient it's on, but not turn it on, and see if that helps. If they say it helped, then there's obviously some placebo effect. In our when we did electric stimulation of the eardrum and the ear canal, and the scalp and all these other areas, then once we found that there were some that worked, then we did sham stimulation to kind of corroborate that this is actually from the stimulation, not from just a subjective sensation. So, in terms of TFI, I think, as I said, TFI is not perfect. I mean, I'm the first to admit it. And, I've sort of tasked one of my team members on working on, developing I've given them questions that they were going to be now testing on people to sort of be able to have a sort of the next generation of the TFI, maybe, that takes some of that granularity in place. But at the end of the day, it's a subjective problem that differs in experience from person to person. The only way to capture that is right now is that subjectively asking the patient how they're doing and how loud it is and how much does it bother them on a day-to-day basis, etc. So the annoyance and this and how does it interfere with the sleep and all that other stuff. So, I think that maybe, and I've seen this on online forums, that there is sort of this, some people are attack the TFI. It's like, this research only showed improvement in the TFI. That's not real. The TFI is still real. I mean, it's still someone's experience. Whether, someone as a sort of non-tinnitus researcher thinks so or not, in my opinion, it sort of doesn't matter, because right now that's the best tool we have. It's the validated tool. It takes into account a lot of aspects of the tinnitus. Is it perfect? Definitely not. But but it takes into account that individual's experience before and after the treatment. A minimum masking level, as I said, generally what we have seen mirrors that, in terms of what, a reduction in the minimum masking level generally is in line with what we see on the THI or TFI changes. People, when the sensitivity is reduced, they perceive the sound as at a lower level, and it has a lower impact on them. But you can have people who have the same minimum masking level, as I was saying, and have a completely different experience. The only way to capture that difference is to subjectively ask them, where were you here? Or were you here? Was it better or not?
Well, speaking of non-tinnitus researcher, now I remember at the beginning of that answer, you spoke about funding, and just a shout out to your interview with Hazel and Brian Fargo on Tinnitus Talk. Um, I remembered listening to that episode probably when it first came out years ago, and this was just before I started going back to school after 20 years away in a totally different career. And that was just when I was getting fired up about tinnitus research in general. And maybe it's because I watch too much TV or something, but you say $1 million, and these days it just seems like there's millions of dollars just floating everywhere, just flying through the sky. I just don't have it. But so I remember hearing that story about the Brian Fargo's offer to match that donation, and I was aware of it. Since then, I've gotten involved in my own research and secured funding for my own lab, and so now I have a very different picture of it. And when I listened to that episode again, just 2 weeks ago or something in preparation for our talk today, the the real gravity of what it takes to secure that funding, and especially for something that now I've spent going on 4 years, just thinking about virtually all day, every day. And yeah, it's a lot. It's a lot. And to roll out something like what you're describing, and what it sounds like you and a pretty small but dedicated team have managed to put together in this amount of time, it's no small feat. And I just a comment, I think that sometimes civilians tend to lose sight of what it really takes, because we see science and research as something that happens like independent of our day-to-day going to the grocery store, driving through traffic life. It's just, oh, the science, it's just there, it's happening, and that's a very real side to it.
Thank you. Yeah, I mean, unfortunately, progress in research in medicine is a long process, and it costs a lot of money. And you know, uh, you need expertise from multiple disciplines to do these things. I mean, we have, we had 3 PhD students in electrical engineering working on our chip. We have an MD PhD student who did the software. I have another electrical engineering faculty and a hearing science faculty, and several consulting electrical engineers, in order to get us to the stage where we have a functioning chip that we can stimulate using the size of coils that we like to use. And now sort of the next stage is to get a kind of a device that's ready for human placement. So that expertise comes from a private company that has made devices that have become FDA approved. So we're now working with a couple of different companies trying to find the right one that can hopefully build us the device that we could then get through FDA approval for the purpose of a trial. So FDA has, even if you're going to do a trial with a new device, you have to get what's called an investigational device exemption. And so we're also in the process of setting up a meeting with the FDA. We have to actually go in with a very big plan of what the device is going to look like exactly, and what safety features it has, and then what our plan for testing would be. And so then we have to get that done, so then that can help guide the development of the device for the trial, and then what things we're going to do in the trial. So and so we have to sort of lay this all out before we get to a trial, so that the FDA can actually approve it for the purpose of a trial. So yeah, it takes a tremendous amount of effort. I mean, even finding the a right person for something like this takes a lot of effort, and interviewing a ton of people to try to find the right person who can actually help you sort of get to the next stage. But one thing is for sure is none of this can happen without money, because while I tend to dedicate most of my time sort of voluntarily to research, because that's just I still have to see patients and do surgery and stuff, but someone who's doing full-time research, if I want a PhD scientist working on this, if I want PhD students, we still have to pay them. We still have to, cover their expenses and their tuition and all that other stuff, which is a sort of a normal in academic medicine, as you probably know.
So once again, you touched on a lot of these points already, but I could see further elaboration. And we're getting near the end of our talk here. But looking ahead, what do you consider your primary research priorities? And do you plan on focusing on further medication trials, implant development, both? Are you collaborating with major research institutions or labs to help advance these efforts?
Our priorities are addressing the two aspects of tinnitus: the sound production, which is we're hoping that the electric stimulation is going to do, at least based on the studies that we did beforehand. And the other is the modulation of the tinnitus, which is the atypical migraine. Those are our two sort of major areas of research. We're also starting some work related to regeneration of the hearing cells, using genetic processes. So we're sort of trying to attack it from multiple different directions. We are fortunate that, I'm very fortunate that I have a very good team. And so we're doing all of it. We're doing the medication trial. We're doing a trial right now for acute tinnitus, because we think that the onset of tinnitus is potentially migraine related in some people. And what I have seen myself, as sort of my own practice, is that I've been able to make tinnitus go away in the very early stages, especially when it's intermittent. So people say I have 3 days of tinnitus and I have a silent day, and then I have like 2 more tinnitus days, and then I have silent day. The ones who get it that those are the people that I have been able to make it go away. So we're now doing a trial to see what is that time point where we can potentially stop tinnitus, and at what point is it sort of the point of no return. And then on the implant side, we have, as I said, we're working on a couple of different things at the same time, trying to get the processes through the FDA to understand what their requirements are going to be, and at the same time, do the development of the actual device for placement in humans. The question about collaborating with major research institutions, I smile a little bit because I think we are a major research institution at the University of California, quite possibly the biggest in the world if you take all of the University of California system together. UC Irvine, we, in just a medical school alone, we have 1,000 faculty members. We have close to 50,000 students. So we're a major research institution, but we will be working with other major research institutions, definitely, especially once we are ready to do a multi-institutional study. And we'll be working with not only centers in the United States, but also other countries as well. We're definitely open to doing that. And I know a lot of people in different countries who are doing tinnitus, really great tinnitus research. And I would love to work with people all around the world, because I think big problems are solved when you have multiple people from different backgrounds coming together and working on the same problem, and having the funding to be able to do that. I personally believe that every problem is solvable if you just get the right people working on it and provide them the right level of funding they need to advance their work.
So I wonder how, given what you just said there, how you might answer this last sort of a final thought. So, your from your perspective, why is Tinnitus Quest a strong platform to foster collaboration and drive innovation in tinnitus research?
Yeah, so tinnitus quest, Sven Coleman again is a visionary behind Tinnitus Quest, and then with the help of Hazel and Marku, as well as Professor Longuth and Professor De Ritter, I think he was really Sven's idea is sort of very similar in terms of what I think is if you just get the right people and provide them funding, then you'll be able to solve anything. And I truly believe that. And I think, it takes a visionary sometimes to do these things because, as I said, at least in the United States, the institutions, the federal, institutions that fund research, they don't fund kind of high risk, high reward research. And tinnitus, unfortunately, as common as it is, it gets very little funding from the national agencies. And you look at, the funding from the so-called NIDCD, which is the group that funds hearing related research. A tiny fraction goes to tinnitus. A super tiny fraction goes to like ear infections, which is something that 90% of children get. But then a giant chunk goes to cochlear implants that only a very small portion of the population ends up getting. Which is, it, I don't quite understand why, because there are only maybe 100 to 200,000 people in the United States that have cochlear implants, maybe a little bit more. But I can tell you, it is there are 100 times more people who have tinnitus than have cochlear implant. But probably the amount of funding that goes to tinnitus research is about 1% of what cochlear implant gets, or maybe it's slightly more, but not a whole lot more. So it's unfortunate, I think, that the funding priorities of national agencies are way different than what the reality reflects and what's causing the biggest problems in people's lives. I mean, is music perception good for tinnitus for people with cochlear implant? Yes, I think it's a great thing. But is it more important than solving tinnitus? I really don't think it's more important than solving tinnitus because, you can help people with cochlear implants hear music. You've helped, 100, 200, 300,000 worldwide, 1 million people. You help find a solution to tinnitus. You've helped, hundreds of millions of people across the world. So, and I'm interested in all of it. I mean, I'm in the hearing, I'm an ear specialist. So I'm interested in solving all of these problems. But if I were to prioritize, I would prioritize things quite differently than the national funding agencies. So you need private sort of visionaries, really, like, Brian Fargo, like Sven Coleman, and others who've contributed to Tinnitus Quest to provide funding for researchers who have great ideas but just don't have the funding to be able to get to the next stage. And so I, and when Sven asked me to be a part of Tinnitus Quest, I said, this is exactly what tinnitus needs. This is something that you need a visionary, we need funding, and we need the right people to sort of find, new researchers who are interested in doing tinnitus. Because there are some, like, very smart neuroscientists or very smart people and do other kinds of research, but they don't want to do tinnitus research because there's no money in it. Nobody's funding tinnitus research in a national level, or it's a very, very small amount. So it's very difficult to get funding for it. So then most people don't go into it until they end up in a sort of one narrow area, even though they could have a great idea that could solve tinnitus. They're just not doing it because there's no money to fund it. The reality is, in people who do research, if you're a full-time PhD scientist or a clinician scientist, you tend to do work that it just gets funded because you need money to pay for stuff. I'm not going to be able to do something that has no funding. I can do it myself for a little bit, just volunteering my own time, but I can't do everything on my own. So I need other people to collaborate, and those collaborators we have to compensate them for their time. And, if they're going to spend their full-time PhD with us, they need funding. If I don't provide the funding, they'll just go to a different lab that has the funding. So, and they won't do tinnitus research. So I think that's Tinnitus Quest. I'm, hopeful will solve a lot of this. I mean, it requires participation from the tinnitus community. I think people who are looking for cure. I mean, if you just think about the United States, we have at least 30 million people who have tinnitus, and at least 10 million people have gone to a doctor for tinnitus, and at least 3 million people are severely disabled by it. If all of these people who had tinnitus just contributed $10, I mean, just imagine the amount of funding there would be for tinnitus. It would be far more than what, is available on a national scale from the National Institute of Health, for example. So, and I think with that level of funding, you can definitely solve tinnitus. I mean, it took $100 million for this research group to figure out to put something on the outside of that head, and for somebody who has quadriplegic to be able to lift a cup up, bring a coffee and drink it and put it back down. When I heard that, I said, "Give me $100 million. I'll solve any problem for you." I mean, you just need smart people. We'll find a team across multiple institutions, all working on the same thing collaboratively, and you can solve it. It just needs money. There are plenty of smart people around the world, and as I said, if there's no money, they're not going to work on tinnitus. And I'm hoping that Tinnitus Quest is going to solve that problem.
That's a really poignant and inspiring. Even as someone who tunes into this, like I've said, every day, it feels like that I learned a lot just from hearing that last answer. That was huge. So thank you so much for your work, Dr. Djalilian, and especially for your time talking with us today. That was very, very informative. And yeah, once again, I'd just like to thank you, just even for myself, for the work you do. It's really great to hear that we've got someone like you on the case.
Thank you very much. I really appreciate you taking the time to talk. I know you're quite busy, so I really appreciate it. And thank you to Tinnitus Quest for putting together all the infrastructure necessary for something like this. So thank you again.
Yeah. Yep. All right. That's it for now.